Hello, I'm Dr. Mark McConnell with the Tomah, Wisconsin VA Medical Center. As mentioned in the previous video, within VHA we hope to foster a culture of shared decision-making where providers and patients collaborate. So how do we, as providers, use shared decision-making when recommending A1C targets for our diabetic patients? That is the question I hope to answer in this brief video. Over the years, many specialty societies, including the American Diabetes Association and private sector performance measures, have created a target A1C for all patients with diabetes of less than 7. It is important to note that recent studies, better known by their acronyms ACCORD, ADVANCE, and VADT, have called into question the wisdom and safety of the one-size-fits-all, less than 7 for all patients approach. We are fortunate that our VHA performance measures have never advised that we target all patients with a goal of less than 7. More importantly, VHA explicitly recommends incorporating patient values and asks us to individualize recommended A1C goals as part of our approach to patient-centered healthcare. To help clinicians determine A1C goals for their patients, we have created a decision aid from our VA DoD guideline that consists of 4 steps. The first step is to categorize each patient along the lines of major comorbidities or life expectancy, and these are listed on the left-hand column of the first table. Major comorbidities may be absent, present, or marked, or the patient may have an estimated life expectancy of greater than 10 years, 5 to 10 years, or less than 5 years. Next, consider any existing microvascular complications as listed in the right-hand column of Table 1. These may be absent or mild, moderate, or advanced. The next step is to plot where your patient lies in the 2 categories of microvascular complications and major comorbidities. This will lead to an evidence-based, individualized A1C target range. Notice that the only patients for which best evidence suggests an A1C range of about 7 are those patients with no major comorbid conditions or a life expectancy of greater than 10 years, and absent or mild microvascular complications. In other words, fairly healthy, physiologically young patients. Unfortunately, the group fitting an A1C goal of less than 7 does not represent the majority of our diabetic veterans, who tend to be older and have more coexisting conditions. One thing to appreciate is that all of the discussion about A1C must include an appreciation that these values are target ranges. Our guideline is explicit in asking us to recognize the variation and lack of precision of the A1C test itself. Keeping this in mind will help us to avoid overreacting to minor, non-statistically significant changes in the A1C values our patients have. If you want to know more about the UK PDS trials and other research studies used to inform our VA DoD guideline, then click on the link below after viewing this video. The third step in a shared decision with your patient is to talk with them and their caregivers to determine their resources in things like motivation, financial impact, safety, and the hassle factor of our regimen when considering how intense the treatment they are willing to accept. To better reinforce the idea of A1C as a range, this visual depiction of a continuum of increasing or decreasing patient values and resources may be helpful as you and your patients attempt to decide on a shared goal for glycemic control. This is not only an evidence-based approach, but it is realistic and centered on your patient. Do you feel confused? That's entirely possible. Many times we feel like we are simply being told what to do. The 2010 VA DoD Clinical Practice Guideline represents a decidedly different approach to patient care. It is an approach that formally advises us to recognize several important points. 1. It is relatively easy to be familiar with the evidence that informs our advice to patients about A1C target ranges. 2. We must recognize the variation in A1C levels in order to avoid overreacting to minor, insignificant changes from one test to the next. 3. VA has never advised that all patients aim for an A1C of less than 7. 4. Using a few simple variables, we can determine a recommendation of 7, 8, or 9 that has the best chance of optimizing benefit and minimizing harm for a patient. 5. We are then encouraged to explore our patient's values and preferences in order to come to an agreement on a shared, informed decision about our patients and their caregivers' specific goals. These goals are always subject to change based on changes in health and preferences that patients may experience. 7. Most importantly, any goal that is not embraced by the patient is not likely to be successful. In closing, the approach one size fits all is not the best way to treat veterans with type 2 diabetes. Rather, we want to use shared decision making to work together with the veteran to arrive at a target A1C range that is a balance of evidence-based results and what the veteran and their caregivers consider important. A link has been provided so you can print off the decision aid as well as a short presentation of the 4 research trials we mentioned earlier. Now, it's time to meet our patient, Mr. Smith.